Assalamu alaikum students. My name is Dr. Amber Ilyas. I welcome you all to the online sessions of gross anatomy lectures at Amiruddin Medical College, Lahore. We were already doing our lectures in the dissection hall on the region of thorax in gross human anatomy, but due to unexpected circumstances, we have to continue our learning on online portal. Today would be my first session with you on the topic of diaphragm. So the learning objectives of today's session would be that at the end of this section you should be able to define diaphragm, define its shape, parts and position, explain the alignment of its fibers, which means its origin and insertion, identify the openings in diaphragm which are very important and all the structures which pass through these openings. Explain the blood supply and nerve supply of diaphragm, describe the function of diaphragm, and understand all the applied relevant clinical aspects of diaphragm. So the first question is, what is diaphragm? Diaphragm is basically a fibromuscular sheet which is dome shaped, and it separates the two cavities of our body, which means thoracic and abdominal cavities. It is not a complete separation because there are many important structures which have to pass from thorax to abdomen, for example aorta and inferior vena cava. So there are specific openings in the diaphragm for that purpose. The main purpose of diaphragm is to help in our inspiration. It is also said to be the muscle of inspiration. As I have pointed out in the diagram is the bottom structure, which is almost pinkish in color, and it is separating our thoracic cavity from the abdominal cavity. It is dome shaped as evident from the figure. The next question is, what is the anatomical position of diaphragm in a human body? When we look at a human body from the front, diaphragm is like a shape of a dome. In fact, there are two domes, right and left domes. The right dome is slightly at a higher level as compared to the left dome, and that is because of the liver which is placed under the right dome. It is said the right dome in full expiration, it almost reaches to the level of nipple or fourth intercostal space, while the left dome, it reaches the level of the lower border of the fifth rib. In the diagram, you can see that on the right side, the dome is separating the right lung of the liver from the abdominal cavity, and on the left side, the left dome is separating the left lung from the abdominal cavity. When we look at the diaphragm from the side of the body, you can see that it looks much like an inverted J. I have drawn an inverted J on the left side of the slide. The long limb of the diaphragm, it corresponds to that part of the diaphragm which arises from the vertebral column, and the short arm part of the diaphragm, it is actually attached to the Xiphi sternal joint. It is clear on the picture as well. Now, when we look at the diaphragm from the top, we can appreciate that it is much like a kidney shaped, and the posterior indentation is basically because of the presence of the vertebral column. In the diagram, you can see the grayish area which is much in the shape of our abdominal cavity, and it is almost like kidney shape, and that is the diaphragm part that I'm referring to. So up till now we have seen that in terms of its position, when we look at the diaphragm from the front, we can appreciate two domes of the diaphragm which are separating our thoracic cavity from the abdominal cavity. When we look at the diaphragm from the side of the human body, it is much like an inverted J shaped, and when we look at the diaphragm from the top, it is like the kidney shaped with the posterior indentation which is due to the vertebral column. So the shape of the diaphragm, as we have seen, it is dome shaped, with two right and left domes. The right dome separates the right lung from the abdominal cavity, the left dome separates the left lung, and the central part of the diaphragm, which is referred to as the central tendon part, it supports the heart. For purpose of understanding, we will say the diaphragm has two parts, the peripheral part, which is basically muscular in nature, and the central tendon part. Now comes a very important aspect of diaphragm, and that is its origin and insertion. Because if you don't understand its origin and insertion, then you can't completely visualize the anatomy of diaphragm. In terms of its origin, for purpose of understanding, we will divide it into three parts. Number one, the part of the diaphragm which arises behind the sternum, and that part we refer to as the sternal part. Then secondly, there is a part which arises from lower ribs and costal cartilages, and we call it as the costal part. From behind, some of the fibers of the diaphragm, in fact majority of the fibers of the diaphragm, they come from upper lumbar vertebrae and from the medial and lateral arcuate ligaments. We will discuss all of these structures in detail. So the sternal part of the diaphragm, it includes those fibers which arise from back of the xiphisternum part of the sternum, which is the lowermost part of the sternum. You cannot appreciate that part in this diagram. The second part is the costal part, which arises from the lower 6 ribs and the costal cartilages, which is this part. Now come to the third part, which is the vertebral part, which is very important, and it has its origin from the first 3 lumbar vertebrae in the form of right crus and the left crus, and then it also has its origin from the medial arcuate ligament and the lateral arcuate ligament. You can see the pointer on the right side of the diagram, which is in fact our left side, and that shows the right crus of the diaphragm. It is a tendinous structure basically, and it arises from the bodies of first 3 lumbar vertebrae and the intervertebral disc. By that I mean L1, L2 and L3. Similarly, on the left side, you can see the fibers of the left crus. These fibers are coming from the vertebral bodies of L1 and L2 vertebrae. These fibers, both the right and left crus fibers, they ascend. The interesting fact is that some of the fibers from the right crus, they ascend and then they loop around like a sling-like fashion. They loop around the esophageal orifice, which is right there. From the medial aspects of the right and left crust, some of the fibers cross over in front of the aorta, and that part is referred to as the medial arcuate ligament, which is almost this part in front of the aorta. Then comes 2 other things that should be aware of. That is the origin of the diaphragmatic fibers from the medial arcuate ligament and the lateral arcuate ligament. So medial arcuate ligament is a thickening in the psoas fascia, and it arises from L2 vertebrae to the tip of transverse process of L1 vertebrae. So this semilunar section that I am pointing at is the medial arcuate ligament. I'll repeat it again. It will arise from L2 vertebrae and then it goes to the tip of transverse process of L1 vertebrae. Lateral to it comes the lateral arcuate ligament. So the lateral arcuate ligament, it extends from the tip of transverse process of L1 vertebrae and then it goes to the inferior border of 12th rib. This is all about the origin of the diaphragmatic fibers from the vertebrae. So to repeat that again, we have seen that the origin of the diaphragmatic fibers, the first part was the sternal part, And the fibers of the sternal part, they basically arose from the posterior surface of the xiphoid process of the sternum. Then there was a costal part, and the fibers of that part, they arise from the inner surface of lower 6 ribs and the costal cartilages. The third part was the vertebral part. Most of the fibers of the diaphragm, they arise from the vertebral part. In general, the fibers, they arise from the upper lumbar vertebrae in forms of crura, and then from the medial and lateral arcuate ligaments. Right crus, as we have seen from the previous diagram, that right crus, it arises from the surface of bodies of first 3 lumbar vertebrae, L1, L2 and L3, and the discs. Left crus fibers, they arise from L1, L2 vertebrae and the intervening disc. As I told you that some of the fibers of the right crus then move to the left, and in a sling-like loop they surround the esophageal orifice. From the medial edge of the 2 crura, the fibers, they cross over in front of the aorta and they form median arcuate ligament. Then lateral to it was the origin of fibers from medial arcuate ligament and the lateral arcuate ligament. Medial arcuate ligament is basically a thickening in psoas fascia, and it extends from body of L1 vertebra to the tip of transverse process of L1 vertebra. There is a small error. It basically extends from the side of the body of L2 vertebra to the tip of transverse process of L1 vertebra. And then we have seen the lateral arcuate ligament, which is a thickening in the lumbar fascia, and it extends from the tip of the transverse process of L1 vertebra to the lower border of 12th rib. So just to summarize, I have told you that the origin of diaphragm, all the fibers, some of them, they arise from the back of the sternum, some of the fibers, they arise from the costal margin, and then most of the fibers, they arise from the lumbar vertebrae in the form of 2 crura, right and left crura, and also from the medial and lateral arcuate ligaments. All of these fibers, they ascend in a dome-like fashion in such a way that we get a right dome on the right side and the left dome on the left side, and then all these fibers, they descend and they get inserted into the central tendon part of the diaphragm. So the insertion of the diaphragmatic fibers, all the fibers with the costal, sternal and vertebral origins, they are inserted into the central tendon part. The diagram shows the grayish area, which is the central tendon part. The view is from the inferior aspect of the diaphragm. It is said that a central tendon part of the diaphragm is a trefoil in shape, which means on the right side of the on the slide you can see that there is a 3-leaved structure that is a trefoil shape. So you can compare it with the central tendon, whitish part of the diagram, and you can confirm that it's a trefoil in shape. Central tendon lies at the level of xiphisternal joint, and it is inseparable from the fibrous pericardium, and that is because of their common embryological origin. So up till now we have discussed the origin and insertion of the diaphragmatic fibers. Now we move on to the very important part in terms of anatomy of diaphragm, and that is the openings in diaphragm. I discussed with you that diaphragm is a fibromuscular sheet which separates the thoracic cavity and the abdominal cavity. But it's not a complete separation because there are some vital structures which have to pass between the thoracic and the abdominal cavity. To aid the passage of these structures, we have some important openings in the diaphragm. For example, we have the aortic opening. Number 2, we have the esophageal opening. And number 3, we have the caval opening. In addition to these openings, there are other small openings in the diaphragm for other small structures. But for your purpose, these 3 openings are the main openings that you should be very clear about. The interesting fact is that all these openings, they are at different levels. If we go from bottom to up, at T12 level we get the aortic opening, at T10-11 we get the esophageal opening, and at T8, which is 8th thoracic vertebra, at that level we get the caval opening. So this is the caval opening, and you can see the inferior vena cava which is going through it. This is the esophageal opening, and esophagus is passing through this. And this is the aortic opening, which is not very clear, but you can see the descending thoracic aorta passing through it. Now a little bit detail of all the openings. Number 1 is the aortic opening. It is at the level of T12 vertebra, and it is exactly in the midline behind the median arcuate ligament, as I told you earlier. The important structures which pass through the aortic opening is number 1 the aorta, number 2 the azygous vein, and number 3 the thoracic duct. The second opening is the esophageal opening. It lies at the level of T10th vertebra. It is not in the midline, but it is slightly to the left, almost 2.5 centimeter to the left of the midline. The important structures which pass through the esophageal opening are number 1 the esophagus, number 2 the esophageal branches of left gastric vessels, number 3 the right and left vagus nerves, and number 4 lymphatics from lower third of the esophagus. The third opening is the caval opening. It is at the level of 8th thoracic vertebrae, and it is in the central tendon. The important structures which pass through the caval opening are number 1 the inferior vena cava, and number 2 the terminal branches of right phrenic nerve. There are several other structures which pass through the diaphragm through their own openings. For example, the sympathetic trunk, it passes behind the medial arcuate ligaments on both sides. The greater, lesser, and least splanchnic nerves, they pierce the crura. The left phrenic nerve, it pierces muscles of the left dome of the diaphragm. So if we just revise all of it, we have seen that there are 3 important openings: the aortic opening, the esophageal opening, and then the caval opening. The aortic opening was at the level of T12 vertebra, esophageal opening was at the level of T10 vertebra, and caval opening was at the level of T8 vertebra. The important structures which were passing through the aorta, through the aortic opening, were the aorta, azygous vein, and thoracic duct. Structures passing through the esophageal opening were the esophagus, vagus nerve, branches of left gastric vessels, and the lymphatics. And from the caval opening, we could see the structures passing are inferior vena cava and the right phrenic nerve branches. Now we can discuss the blood supply and the nerve supply of the diaphragm. Those fibers of the diaphragm which rise from the costal margin, they are supplied by the lower 5 intercostal and subcostal arteries, while the fibers which arise from the crura, they are supplied by the branches of the abdominal aorta, and the name of these branches are the right and left inferior phrenic arteries. In addition to these 2 major supplies, there are other small contributions from internal thoracic artery and the thoracic aorta. The next important thing is the nerve supply of diaphragm. The motor supply of the diaphragm is exclusively from the phrenic nerve, and the root value of the phrenic nerves is C3, C4, and C5. We have 2 phrenic nerves, right and left phrenic nerves, which go to each sides of the domes of the diaphragm. When it comes to the sensory supply of the diaphragm, the part of the diaphragm which is at the periphery, it gets a sensory supply from the lower 6 intercostal nerves, while the peritoneum, which covers the central part of the diaphragm, that is supplied by the phrenic nerve. For you to understand, there is a mnemonic which you can recall as C3, C4, and C5 keep the diaphragm alive. So C3, C4, and C5 keep the diaphragm alive, which means that diaphragm motor supply is solely dependent on the phrenic nerve, and any damage to the phrenic nerve will lead to the damage of the diaphragm or the paralysis of the diaphragm. After the nerve supply, we'll move on to the functions and actions of the diaphragm. There are 4 important functions which are linked to the diaphragm. Number 1 is that diaphragm is considered as a muscle of inspiration. Number 2, the actions of the diaphragmatic muscles, they help in the thoraco-abdominal pump, which we will discuss in later. Number 3, diaphragm helps in weightlifting. Number 4, the role of diaphragm in abdominal straining. The details of all this you will discuss in your physiology sections, but a brief introduction of all of this will be continued now. The muscle of inspiration. Why do we call it? You can see from the diagram. What happens is that when the diaphragm muscle contracts, the dome of the diaphragm, it descends, and the lungs get the space to move down, and in this way air moves in. But when the expiration occurs, the muscles of the diaphragm, they relax. In case of tranquil or normal respiration, the fibers of diaphragm contract and only the dome part of the diaphragm descends. The mediastinum is undisturbed. When we do deeper inspiration, there is further descent of the domes of the diaphragm, which leads to the depression of the central tendon, and that central tendon depression stretches the mediastinum. The mediastinum stretch prevents further descent of the central tendon. When we do maximum inspiration, further contraction of the diaphragmatic muscle occurs, which causes eversion of the ribs, and the subcostal angle is widened. One thing you should be very clear about is that the diaphragm is a muscle of inspiration. When the diaphragm muscle contracts, they help in inspiration. But diaphragm is completely passive in expiration. Either it is tranquil or forced expiration. It has no role in it. Next important function of the diaphragm is its role as thoraco-abdominal pump. How does that occur? When the fibers of diaphragm contract, that leads to the descent of the domes of the diaphragm, which means that the domes of the diaphragm will move down. When they go down, the intrathoracic pressure falls and the intra-abdominal pressure rises. This change in pressure gradient in the 2 cavities on both sides, that will help in the return of venous blood through the inferior vena cava to the right side of the heart. The similar mechanism also helps in the movement of lymph upwards in the thoracic duct. The third function of the diaphragm is its help in abdominal straining. How does that occur? When the diaphragm muscle contracts, it assists the abdominal wall muscles to increase the intra-abdominal pressure. That increase in intra-abdominal pressure is important for our physiological processes like micturition, defecation, and parturition. To further aid this mechanism, we can take a deep breath and close the glottis of the larynx also. And the next important function is the role of diaphragm in weightlifting activity. When the weightlifters, they take deep breath and they hold it, they actually fix the diaphragm. In that posture, the diaphragm assists the abdominal wall muscles to raise the intra-abdominal pressure, which supports the vertebral column and prevents flexion of the vertebral column. In this way, the vertebral column is supported, and it also aids the post-vertebral muscles in lifting the heavy weights. Last but not the least, I would like to discuss with you few important clinical anatomical aspects of the diaphragm. First of all is the hiccup. Diaphragm, interestingly, it is a muscle of hiccup. What is the hiccup? We all know from our childhood that hiccups, they are the sudden contractions of our body, making some very, very funny sounds. But in reality, they are basically the involuntary contractions of the diaphragm. In normal individuals, they can occur after eating or drinking, and that is because of the gastric irritation of the vagus nerve endings. But in some diseases, we can also see uncontrollable hiccups, like in case of peritonitis, pericarditis, uremia, etc. The other very important thing clinically is whenever a patient comes to you with any sharp stab or bullet wound injury to the chest or abdomen, particularly when it is at the level below the nipples, that should always raise a suspicion of diaphragmatic injury in your mind, and that is because of the level of the domes of the diaphragm that we have discussed already. So any penetrating injury to the chest or abdomen can cause damage to the diaphragm as well, and that should be ruled carefully. The next important clinical aspect is the paralysis of the diaphragm. I told you that for diaphragm C3, C4 and C5 keep the diaphragm alive. Any damage to the phrenic nerve, any sectioning, crushing, any traumatic injury to the phrenic nerve, that leads to paralysis of one dome of the diaphragm, which we call as hemidiaphragm. You can see in the diagram that one dome of the diaphragm, which is particularly right, has gone quite up, while the left dome of the diaphragm level is quite low. Very important fact for you is that whenever there is paralysis of the diaphragm, that side of the diaphragm will always be at a higher level, and that is because when the diaphragmatic muscle is normal, the muscle contracts and they go down, but the paralysis of the diaphragm leads to the immobility of that part of the diaphragm, and the level is always higher as compared to the normal part of the diaphragm. So in this case, you can see from the X-ray that the right side of the diaphragm is the paralyzed side, not the left part. Lastly, it's about the hernias of the diaphragm. Some of them are congenital while some of them are acquired. The congenital hernias, they are a result of incomplete fusion of embryological components of a region. You will learn in your embryology classes that the origin of the diaphragm embryologically is from the septum transversum, pleuroperitoneal membranes, and dorsal mesentery. Whenever there is any defect or incomplete fusion of these structures, it will lead to congenital hernia. The other important aspect is the hernia which is acquired almost in the middle age, and that we call them as acquired hernias. They are a result of weakening of diaphragm musculature around the esophageal opening. There are particularly two types of acquired hernias. One is the sliding esophageal hiatal hernia, which is shown as A on the figure, and then we have the paraesophageal hernias, which is shown as B in the figure. The main difference between the two types is that in the sliding esophageal hernia, there is a weakening of the diaphragm muscle around the esophageal opening, and the part of the stomach along with the esophagogastric junction, it goes up into the thoracic cavity. While in case of the paraesophageal hernia, the esophagogastric junction lies in its normal place, but a part of the stomach, it moves up through the weakness. You can see that clearly from the two diagrams. In figure A, a part of the stomach had ascended through the weakness of the diaphragm along with the esophagogastric junction, while in figure B, the esophagogastric junction is beneath the diaphragm, but a part of the stomach has ascended through the weakness, and that is why we call it as a paraesophageal hernia. There are many other clinical aspects that you can read from your textbooks, but that brings us to the end of this lecture. I hope you had learned the basic concepts and anatomy of the diaphragm. Thank you very much, students, and all the best.